Welcome to a discussion about the reticular formation involved in wakefulness, sleep, and coma. We will identify the location of the reticular formation, describe the role of the reticular formation in consciousness, sleep, wakefulness, and coma, and examine the common rhythms of the EEG, alpha, beta, theta, and delta, some of the phasic events that occur in sleep during REM and non-REM, the neurotransmitters involved in the regulation of sleep, and the function of the suprachiasmatic nucleus in circadian rhythms. We want to examine this because it turns out that the reticular formation contains many of the structures that regulate consciousness. It's a very important part of the system that regulates sleep and appetite. It serves as a source of many of the sites of origin of neurotransmitters required for the rest of the brain. And understanding anatomy and physiology of this structure helps us diagnose patients that might be comatose. And many of the very common sleep disorders result from dysfunction. Consciousness can be thought of as two features: arousal, that is just awareness, and then the content of that awareness. If you have arousal, which may be dependent on the brainstem, without content, then we would be in a vegetative state. That is, if the cerebral cortex were not functioning, but the brainstem was, you might have arousal but have no meaningful content to that arousal. It would be impaired consciousness. But content does not appear to exist without arousal. That is, if you damage the brainstem, then having the cortex functioning does not seem to be beneficial. Sleep is a distinct state in which the brain does not permit most of the motor output used to determine consciousness, so that when you're asleep, you're not evaluating motor function generally. A few definitions. Coma is a state in which there is no stimuli, internal or external, that will arouse a patient to consciousness. And those internal might include hunger and thirst that don't wake a person up. And external might be noise, light, flashing lights, verbal commands, or pain. A variety of other states that are in between full awareness and coma include stupor, when the patient is unresponsive unless they are stimulated, or obtunded, when the patient is often unresponsive but once in a while can arouse. And these patients may look as if they're asleep, but brain waves, EEG, the electroencephalogram, shows that they are not asleep. The EEG tells us about this brain activity, and it is derived from excitatory postsynaptic potentials and inhibitory postsynaptic potentials of a large number of neurons in the superficial cortical layers. And it's broken down into various frequency ranges that give us some indication of the condition of the brain. Alpha, which is 8 to 13, beta, 14 to 30, theta, 4 to 7, delta, less than 4 hertz, and gamma, more than 30 hertz. Don't worry about these frequencies. Just recognize that alpha and beta are associated with waking behavior. Theta and delta, those are normals. Theta and delta are associated with sleeping behavior primarily. And then gamma is sometimes associated with seizures. But also recognize that some of these frequencies, particularly theta and delta, may be seen in comatose states as well. Normal EEG patterns include, in a normal waking adult, beta in the front of the brain, alpha in the back. It's generally symmetrical. Alpha activity blocks with eye opening because the visual system drives the thalamus and the cortex. And there are lots of eye movement artifacts. During drowsiness, there's loss of alpha and an increase in theta activity. During sleep, there might be sleep spindles, some fast activity, and some theta activity. As slow sleep becomes more prominent, deeper sleep, we'll see that delta activity predominates. And then every once in a while, REM sleep, rapid eye movement sleep, also known as paradoxical sleep, appears, and it resembles the waking EEG, but there are lots of eye movements and other features, as we'll see. If you look at the various levels of EEG that can be observed in a wide awake person, you might see low amplitude. Don't worry about the details of these, but we'll get into some features that you should be aware of. There's low amplitude, desynchronized activity, mixed frequencies, a lot of beta. And then if you close your eyes, then alpha rhythm predominates, particularly in the back of the head. We're looking at just one location and moving the electrodes in different locations. If you start to become drowsy, then alpha will start to disappear, theta will start to appear. As you become sleepy, sleep spindles, as seen here, will appear, as well as some mixed theta and delta. As deeper sleep ensues, you'll see more and more delta activity. There's low frequency activity. And then if somebody is comatose, you might see domination of delta activity and even slower than delta, and it is not able to be interfered with. Whereas all of these other waveforms vary throughout the day and throughout the night. And we'll be looking at normal EEG, shown here from various locations, show a dominant alpha rhythm in the back of the head on the left and on the right. And when the eyes are opened, the alpha is blocked and desynchronized waking activity. So this is what would happen if you close your eyes, and this is what happens, and it lets us know that there's a responsive system to visual input. In slow wave sleep, we see lots of delta activity all over the head, indicating essentially a very deep resting level of activity. And then every once in a while, rapid eye movement sleep occurs, and the EEG looks somewhat more like a wide awake, but there are evidence of movements of the eyes that are very dramatic. If we look at those two different stages of non-REM or slow wave sleep, that's the deeper sleep, we see large, slow, synchronized waveforms in the EEG. We see a somewhat decreased muscle activity. There is rest. It's more difficult to arouse a person during sleep than during wakefulness. There might be a few dreams that are rather vague. And there's a great emphasis on parasympathetic activity. That is, when you go to sleep, you close your eyes, the pupils close, and this tremendous enhancement of autonomic activity of parasympathetic type. And that includes a slow, regular pulse and slow, regular respiration. In rapid eye movement sleep, also called paradoxical sleep, the EEG is low amplitude, vast frequencies, that is beta activity primarily, and it's desynchronized. Muscle tone is actively suppressed. It's almost abolished. Very striking. And then it's very difficult to arouse a person from REM sleep. And there are prominent dreams quite often that are detailed, visual, and emotional dreams. Increased sympathetic activity, markedly activity, just as you are when you're wide awake, even though you might still be deep asleep. And there's irregular pulse and respiration. If we look at sleep throughout the night, as a person first is awake, they have desynchronized EEG with lots of beta activity. As they gradually go to sleep, any alpha activity that might have existed will start to disappear. As they get deeper and deeper in sleep, they'll show within an hour, they'll typically show deeper and deeper sleep and get down to delta activity. And then about an hour and a half later, about 90 minutes later, they'll start to climb back up and they'll have a bout of REM sleep. And then this REM, non-REM will cycle down. So they'll go back down to slow wave sleep about 90 minutes later, and then gradually climb back up and have REM sleep. And each time, every 90 minutes or so, they'll cycle back down to slow wave sleep and then come on back up to REM sleep. And we see that cycle throughout the night. That's a normal sleep architecture. That architecture occurs throughout the night while you're asleep, and to a very much lesser extent, but also during the day. So we actually cycle in our alertness with roughly a 90-minute cycle, the level of alertness that we have, even if we're not going to sleep. Now, if we look at the sleep architecture over several days, we see that most of the time during the day, of course, beginning in the morning, you wake up, You're awake throughout most of the day, and then as you go to sleep, you'll go through the cycles that we talked about. That is the sleep architecture for one night, and you'll go from wakefulness to sleep to REM and back up several times during the night, and then wake up the next day in the morning and be awake for a period of time, and then go through sleep cycle, then wake up, and this happens throughout the day. That's approximates the circadian rhythm. And we can see that among several other things that are happening during that time. During that time, during wakefulness, we see shifts in both body temperature, muscle tone, mental activity, autonomic activity, pulse, respiration, as well as hormonal releases. This is happening on a regular basis every day as we go to wake up, go to sleep, wake up, go to sleep, and wake up. If you damage the suprachiasmatic nuclei in the hypothalamus, that's just above the chiasm, it destroys the normal sleep architecture. So this is normal sleep architecture following approximately the circadian rhythm, the day-night cycle. Destroy the suprachiasmatic nucleus. You do not see that. And sleep is irregular. You jump back and forth between REM sleep and wakefulness, and various slow-wave sleep without that normal sleep architecture, and temperature also, and a variety of other measures oscillate in a much more random way. Sleep disorders are a major source of disability. They include several features that might be difficulty in initiating sleep, difficulty in maintaining sleep, excessive daytime sleepiness, and even sleep apnea, because part of the shifts during sleep normally linked to breathing, and breathing is usually altered during sleep, but it may be altered inappropriately, and that's one of the disabilities that can show up. The reticular formation is a structure we want to discuss. Reticular refers to resembling or forming a network. At most levels of the brainstem, the reticular formation can be divided into three longitudinal zones arranged in a medial to lateral sequence, and we'll pay particular attention to the raphe nuclei. Raphe referred to the seam that is near the midline of the brainstem, and it's a thin plate of cells in the immediately adjacent to the sagittal plane, and we'll see examples of those at several locations. The medial zone of the reticular formation is just lateral to the midline raphe nuclei and has a mixture of large and small neurons, and is the source of many of the long ascending and descending projections from the reticular formation. Some of those neurons in the medial zone of the rostral medullary reticular formation are so large that the area is referred to as the gigantocellular reticular nucleus, and it sends its fibers long distances. The lateral zone, which is particularly prominent in the rostral medulla and caudal pons, is mostly concerned with cranial nerve reflexes that you've learned about and visceral functions. We see here various sections through the brainstem, midbrain, pons, and medulla, and recognize the traditional long tracts you know of, the corticospinal tract, the posterior columns, and the spinal thalamic tract. But in the midst, in the central area of the brainstem, recognize a lavender or pink area. This is the reticular formation, and we see it here at the lower medulla, the cervical medullary junction. We see it here a little bit higher up in the medulla. In this, again, tegmental region. Coming up to the pons, we see it in a central region again at each of these. And in the midbrain, we see it extending again, all dorsal to the cortical spinal tract. At all of these does not include the cortical spinal tract, and it's medial to the medial lemniscus and the spinal thalamic tract that we see out here. If we would look through a longitudinal view of the brainstem, we can see the raphe nuclei here in blue, immediately near the midline. extending all the way from the midbrain down to the medulla. And we see some other reticular nuclei, and don't worry about the names of these cuneiform and subcuneiform nuclei. Just recognize that they're reticular nuclei that are along the midline, and they have something to do with activating the rest of the brain. And then a little more lateral, we see some other portions of the reticular nuclei. And we can see those in cross sections represented here with the raphe nuclei. There are multiple raphe nuclei. We're not interested in the names of the different ones, just the raphe nuclei are fine. And they're right near the midline. You see the periaqueductal gray here. And you see this at a decussation of superior cerebellar peduncle. You see the crus cerebri here, substantia nigra. If we look at a long longitudinal view through the brainstem, we can identify individual neurons using Golgi stains that extend from one end of the brainstem to the other and innervate both all the way up to thalamic nuclei and all the way down through the medulla to the spinal cord. And the reticular formation is very much activated by inputs from all of the sensory pathways, as well as interacting with the thalamus and the hypothalamus. And from there, input goes to a broader part of the brain. If we look at these cross sections of brainstem, we see here that in the pons, where you have some of the pontine reticular nuclei, and in the medulla, medullary reticular formation, they send fibers down through the reticulospinal tract that you have heard about in the past, reticulospinal tract that has an influence, comes all the way down to the spinal cord, and it will influence the activity of lower motor neurons. And it actually, during REM sleep, this area is very much activated, and it controls the activity of lower motor neurons by inhibiting their activity. And as a result, you have a tremendous decrease in tone driven by that system. Recognize that this system also may have an input on controlling reticulospinal pathway, on controlling afferent input through the pain system. We see here, and I wouldn't want you to worry about where the locations are in any great detail, but you see both the raphe nuclei that are close to the midline, and here we are in the midbrain, and just recognize somewhere near the midline, and it's well above, down way below here would be the corticospinal tract, but up much higher, close to the ventricle. You see the dorsal raphe nucleus, and you also see a little more lateral, the locus ceruleus. We will give some attention. Don't worry about the location other than that we see it here in the midbrain. Recognize it's in the midbrain and it's off the midline, as opposed to the raphe, which is right near the midline. We also see here in the medulla, again in the tegmentum, we see portions of the reticular formation on each side, just above the olive. As we're in the pons, and we see high up on just lateral to the fourth ventricle, we see the locus ceruleus. And if we look at these structures in a mid-sagittal section, we can see that the reticular formation sends fibers down to the reticulospinal pathway to the spinal cord. But we also see that the locus ceruleus, the reticular formation, the raphe nuclei in particular, utilize serotonin as their neurotransmitter. Locus ceruleus, located a little bit higher up here in the pons, utilizes serotonin. Utilizes noradrenaline, and it's going to send very widespread distribution to the thalamus, to the hypothalamus, and through the entire cerebral cortex. so including the amygdala, which is heavily involved in emotion, and to the hippocampus, which is very heavily involved in memory. So this system tends to activate very large portions of the cortex. And of course, if you have a system like the amygdala, it's going to be involved in emotional activity, and of the hippocampus, that's going to be involved in memory. You might very well want to have the system, the nervous system, very much activated in order to express emotion as well as to remember. I should go back and mention the medial forebrain bundle is what brings that activity forward to the brain. If we look at these cross sections through midbrain, pons, and the medulla, we can see some of those nuclei that are part of the reticular formation, the raphe nuclei again, just hugging the midline here in the pons, further down in the pons, and in the medulla. And don't worry about the detailed names, they're multiple, as we said, raphe nuclei. We see some of those spread out here. And again, these are the raphe nuclei that send their fibers both down to the spinal cord as well as up through the entire brain. And they also can modify the activity of the entire brain, and they send activity to thalamus, hypothalamus, and the septal region. And that information is traveling to a large extent via the medial forebrain bundle. We see here in this mid-sagittal section some of the other structures we see here that we want to mention and the neurotransmitters that are associated with them. So we see the raphe nuclei here, and we recognize that they utilize primarily serotonin. We see the locus ceruleus a little bit further up and a little more lateral that utilizes primarily norepinephrine and sends that to wide portions of the brain. Each of these are sending to wide portions of the brain. We see the midbrain reticular formation, which utilizes primarily acetylcholine, which will send its input strongly to the thalamus. We see one of the mammillary nuclei that utilizes histamine, that also interacts widely with the rest of the cortex. Recognize that histamine might be a structure that utilizes histamine as a neurotransmitter that influence overall excitability of the brain, might be very much influenced by the various medicines that we utilize that are antihistamines that of course have drowsiness effect. We see here the lateral hypothalamus, which utilizes orexin as a neurotransmitter. And lateral hypothalamus is heavily involved in feeding behavior, and feeding behavior is very much an activator. The feeding systems in the hypothalamus are very much involved in activating the entire brain. And we see the basal nucleus of Maynard in the basal frontal area, which also utilizes acetylcholine. It is one of the major suppliers of acetylcholine to the cerebrum. Also involved in alert. We see those a little bit larger in this location so that we can see the raphe nuclei, the locus ceruleus, the midbrain reticular formation, portion of the mammillary bodies and lateral hypothalamus, the basal nucleus of Maynard, and we see the preoptic area. And the preoptic area is getting visual information, and that also recognized visual information influences all of these regions in terms of excitability. And of course, the day-night cycle is linked to light coming into this area. We can see that during wakefulness and sleep, the activity of various of these structures varies tremendously. I'm not interested in the details of these, but we want to recognize that the preoptic area utilizes a neurotransmitter primarily of GABA, and that it is very active during wakefulness, during non-REM sleep and during REM sleep. So these are sleep areas. So GABA is a dominant neurotransmitter during sleep, whereas all of the other areas tend to be involved, and they're all linked to the reticular formation, either in the reticular formation or linked very tightly to it. And they utilize this mix of neurotransmitters, orexin, histamine, serotonin, norepinephrine, acetylcholine. Do know the link between these structures and the neurotransmitters, and just recognize that all of these are activated during wakefulness, whereas GABA is the prominent neurotransmitter during sleep. REM sleep being an odd fellow of a mix of sleep but apparently active activity in the EEG and various other psychic phenomena, has significant increase in acetylcholine as well as GABA during that period. As I say, don't wrestle with what's up and what's down. Recognize that there is a balance between all of these during different levels of wakefulness and sleep, and that these structures that we see here, lateral hypothalamus, mammillary nucleus, the raphe, locus and ceruleus, and midbrain reticular formation, are very active during wakefulness, and that's part of when we are most alert and conscious. We see those structures built up here and recognize the midbrain reticular formation utilizes acetylcholine, is sending much of its information to the thalamus as well as to deeper structures. Unconsciousness. What is it? Consciousness depends on the interaction of the reticular activating system and the cortex. Only a very small number of anatomical problems can cause unconsciousness. Small levels of damage to the reticular formation can produce unconsciousness. Dysfunction of both cerebral hemispheres, extensive dysfunction of both cerebral hemispheres, can produce unconsciousness, and a disconnection of those systems. So by far the most common cause of a change in consciousness is due to a shift, a small degree of insult to the reticular formation. In evaluating a patient who is comatose, there are a variety of different measures you can use. You can use physical examination based on pupillary responses, extraocular movements, including roving eye movements, cervical ocular reflexes, if the cervical spine is intact, vestibular ocular reflexes, as well as vertical eye movements. Because all of those movements, of course, are dependent on the cranial nerves 3, 4, and 6, and their interconnections. And you recognize that parasympathetic control of the pupil is determined both by the third cranial nerve, which comes right near the midline from the Edinger-Westphal nucleus, and damage in that area obviously might affect both pupil as well as alter consciousness. More laterally, we have the sympathetic control of pupil size coming through the descending parasympathetic region, but we also have the origin in the hypothalamus. So damage to the hypothalamus may also reduce sympathetic tone and result in alterations in consciousness. There are several different locations in the brainstem that result in shifts in the basal level of pupillary activity that gives some hint of why a person may be unresponsive, ranging from those in the diencephalon, thalamus, hypothalamus, in which you get small reactive pupils, a variety of effects of drugs and metabolic encephalopathy, in which you get very small but still reactive pupils, damage in the pretectal area, in which you have large, relatively fixed pupils that oscillate a little bit with hippus, damage in the pons that might lead to pinpoint pupils, damage in the midbrain that might lead to mid-position fixed pupils, and third nerve damage that is due to uncal herniation that gives you dilated and fixed pupil on one side. I'm not worried about you knowing all of these. Simply recognize that damage looking at the pupil might give you some indication of where in the brainstem or in the thalamus there is abnormality responsible for this person's coma. You'll get to know these in the future on a regular basis. These cranial nerves, of course, 3, 4, and 6 are linked by the medial longitudinal fasciculus, and that information also goes down to the neck stretch receptors as information from there as you move your head. So that as you normally look at the eyes, they might be in neutral position. As you move the head to one side, you might see the eyes going back to the side, staying in the position that they had been in. And if you turn the head back, they should also stay in the same position as we saw originally. If you have damage in the brainstem at the pontine tegmental area, in this case from Wernicke's encephalopathy, you might see this kind of deviation of the two eyes. Further evaluation of the comatose patient might include respiratory patterns that suggest damage at different locations in the brain. And they come with the names that you see here: Cheyne-Stokes, central hyperventilation, apneustic respiration, ataxic respiration, and apnea. Don't dwell on these names at this point. We'll get into those in the future. But just recognize that different patterns may give you some hint of what part of the brain, in particular what part of the brainstem, is involved in this patient who is comatose. So, for instance, this waxing and waning signal that you see here of breathing might indicate damage in the thalamus, whereas this rapid breathing that you see here and might indicate damage in the midbrain. This rather slow breathing, very slow breathing, might indicate damage further down in the towards the pons. And as we get a little bit lower, we see that there might be bursts of breathing and then long periods without breathing. And then as you get more lateral in the medulla, you might see a loss of breathing altogether with bilateral insults. Further evaluation of the comatose patient is the assessment of motor responses. So if there is defensive or localizing response to stimulation, painful stimulation, it suggests that the corticospinal tract is active in controlling lower motor neurons. If the person is able to withdraw it from pain, it indicates that the corticospinal tract is functioning and controlling lower motor neurons. If instead you have flexor or decorticate posturing, that's where the arms are up, it suggests that the rubrospinal tract is still functioning, and that's controlling the lower motor neurons, particularly in the arms. So this flexor posturing on stimulation suggests that there's damage just above the rubrospinal tract. If there is extensor or decerebrate posturing, it indicates that there's damage that's taken out the rubrospinal tract and it is left of a vestibulospinal tract. So the vestibulospinal tract is driving lower motor neurons, and they tend to be extensors in the arms and legs. We see examples of those here, and that is if you have a hemispheric lesion, you might have still on the opposite side, you might be able to have on one side corticospinal control that you can avoid painful, you can fight off painful stimuli. But you might see an upgoing toe because there is damage to the Babinski tract on the opposite side. If you have damage that's bilateral and starts to affect the brainstem to the extent that the reticulospinal tract is still working, but the corticospinal tracts are blocked, then, the rubrospinal tracts are still working, then you'll find then on posturing with strong stimulation, you might find both arms are flexed up and the legs are extended. If there's damage further down so that the red nucleus is destroyed but the reticulospinal tract is still working, then, the red nucleus is destroyed so the rubrospinal tract is no longer functioning, but the vestibulospinal tract is still intact, then you will find that the arms are extended, the legs are extended, and that's a decerebrate posturing. and it's an ominous posture because it suggests that respiration might be suppressed shortly, and it calls for emergency action. In searching for the various locations in the brainstem that might be responsible for coma, Tony Damasio and others examined a large number of patients who were comatose and determined what part of the brain was most affected and most involved. And they said they found that in most people, the lesions overlapped in the rostral, raphe complex, the locus ceruleus, the dorsal tegmental nuclei, and surrounding regions of white matter in between those nuclei. So this is within the brainstem tegmentum. It includes the reticular formation and some of the nuclei that are immediately adjacent. These are summarized here, and it simply shows that at various levels of the brainstem, concentration of damage within the pons, in the dorsal region of the pons, in the tegmental region, are the patients most likely to be in coma. Historically, people recognized the brain was important for consciousness, and it was actually viewed as a form of sleep. But some recognized that it was associated with supratentorial lesions, perhaps cortical dysfunction. But increasingly, as we've had CT scan, almost all the data beforehand came from autopsies. Increasingly with CT scan, we have a better indication of where the abnormality might be. It's clear that several of those patients who are comatose have various herniation syndromes in which there's pressure on the brain that pushes tissue from the cerebral compartment lower down and may cause consciousness when pressure is put on the brainstem, disrupting the reticular activating system. Since the total volume in the brain of the cranial vault is limited, introduction of a mass lesion, whether it's due to swelling of an infarct or a hemorrhage or a tumor, it pushes the pre-existing cerebral cortex downward. And displacing first cerebral spinal fluid, but once cerebral spinal fluid limit is exhausted, then the intracranial pressure increases. Brain tissue is highly elastic, so that pressure causes herniation. And the central herniation pushes the brain down towards the foramen mass. Uncal herniation is one of the more common features coming from the temporal lobe when the temporal lobe is forced over the tentorial edge into the midbrain, and that can precipitate death if it's not addressed. And it often, such herniation compresses the third cranial nerve, particularly the parasympathetic fibers on the outside of the third nerve, and that's sometimes associated with a blown pupil, the wide open pupil that you see, as well as the lateral deviation of the eye subsequently. The model that seems to best represent what's happening is this pressure from the temporal lobe pushes on the diencephalon, that is the thalamus and hypothalamus, against the midbrain, and the uncus is sitting right at the medial portion of the temporal lobe. And we can see in doing so, it might hit the third cranial nerve, which is sitting at the midbrain, and stretch the third cranial nerve. And you see evidence of that in this herniation condition in which there's a mass in the left hemisphere. And you can see that a similar feature in this gross specimen of an individual died with a herniation. In this more recent image, you see also from a brain abscess, a large mass that's pushing the brainstem to the opposite side and causing this shift that compresses reticular formation in this region. There are some situations that look like coma but are not. And one of those is the locked-in syndrome, in which patients are wide awake but can't move their arms, face, or legs because of basilar artery thrombosis, which led to pontine infarction, hitting the entire base of the pons. That might leave vertical eye movements spared because they're represented up in the midbrain. And one other condition that you might see this is in very severe Guillain-Barré syndrome, in which all movement is eliminated, even though it's a peripheral nerve disease. But even pupillary reactivity can be affected. And in order to appreciate that that person is conscious, you may need EEG monitoring to see whether the patient is alive. As summary, we recognize that normal sleep and wake behavior is dependent on the reticular formation and the nearby suprachiasmatic nucleus in the thalamus. Recognize that consciousness is dependent on the reticular activating system, activating the cerebral cortex, and that damage to these structures may result in either sleep disorders, which are very common, or in coma, and if more advanced, may result in death. Thank you. If you have any questions, don't